इंद्रानी मैम आ गए?
अभी तक तो नहीं।
Ankur, you can start. Live streaming has been started.
स्टार्ट करो। Okay, am I audible, sir?
Yeah.
Good evening, one and all. On behalf of ISA National, I, Dr. Ankur Khandelwal, welcome you all to yet another academic session of ISA on Monday. So today we have another very important session. It's a master class on complications of regional anesthesia. So before we begin the session, let's pray for Saraswati Vandana, everyone. Screen share. Sir, I'm not getting the option of screen share.
Now you can.
Yes, sir.
Ankur, there's no volume.
We cannot hear. There's no volume.
अंकुर, तुम्हारे उसमें ना 3 डॉट्स आ रहे होंगे, उस पे क्लिक करोगे, उसमें आएगा ऑडियो.
Thank you everyone for your kind attention and hearing. May I now invite Professor Naveen Malhotra sir to address the August gathering and put forth encouraging words to the delegates. Naveen sir is not there?
I don't think so. You can ask Rajiv sir.
Yeah. May I now invite Rajiv sir, Honorary Secretary of ISA National, to kindly address our delegates for today's session.
Just a moment. Good evening, everyone.
So,
I welcome you to the master class on regional complications of regional anesthesia. So we know that in day-to-day practice, It's quite common. We are using regional anesthesia, maybe in the form of spinal, epidural, blocks, everything. So in our practice, it is very important to take care of, we should not go for any complication. So we should know what are the complications that can occur during the regional blocks. Like if we go for spinal, there is sudden hypotension, it can take place, bradycardia, and we know that why it occurs, maybe because of sympathetic block, high spinal, something like that. Other than that, what is more common is PDPH, post-dural puncture headache. So how to go about it? What are the precautions we should take so that the patient do not observe this post-spinal headache? Then there is a urinary retention when we are using long-term, long duration anesthetics like bupivacaine, and particularly it is more difficult in case of children. I have seen in practice surgeons, they always say, don't give epidural or caudal block to the children because, there is retention of urine, and they might ask again and again to the surgeons that that patient is having some problem. So these are the things which we need to take care. Other than that, we have to take care that coagulation profile is correct, platelet count is correct, so that while after the spinal anesthesia or epidural, there is no hematoma. I have seen one case referred from somewhere after a cesarean section. There was a huge hematoma, and we had to operate it for that. So these are certain things that which we need to take care, and we have to see in preoperative assessment what kind of patient is, and what all we have to see before giving any regional block, or we go for the regional anesthesia. So I would like to hand over the session again to Ankur to start the academic session.
Thank you so much, sir. In a nutshell, you have highlighted all the important complications, but then throughout the course and this masterclass, we will have a good discussion on the important topics laid by Parul Madam. May I now invite Professor Naveen Malhotra, sir, to kindly address the gathering.
Thank you, Dr. Ankur. Good evening to all.
Good evening, sir.
Today we are going to discuss a very important and practical topic, but I will believe that Dr. Parul will lay stress on prevention. So complications and side effects should be prevented. Yes, definitely, if at all they occur, they should be managed appropriately and promptly. And as Dr. Rajiv was discussing about different aspects, at the same time, we have to take care of the aseptic precautions also, and also the drugs and the adjuvants which we are using, because these are also an important concern where we have to be very, very cautious what drugs we are using and what adjuvants we are using. Though she will be talking about anesthesia, but since I am a pain physician, I can tell you that you are using omnipaque dye or using local anesthetic and corticosteroid, which require some dilution. So there are certain particular things pertaining to that. But I wish Dr. Parul will be covering majority of those pertaining to anesthesia, and wish the delegates learning session. Over to you, Dr. Ankur.
Thank you so much, sir, for your important words. I'm sure we will have a great session and all the delegates would have certain important take-home messages after the session. So, to chair this important session, we have with us Professor Indrani Hemant Kumar, ma'am. She is currently professor and head at Symbiosis Medical College for Women and SU HRC Pune, and she is the GC member of ISA National. She is also the past president of RSCCP National, state chapter of IAPA, current governing council member of Indian College of Anesthesiology, GC member of Society of Onco-Anesthesia and Critical Care, GC member of Association of Medical Consultants Mumbai, GC member of Maharashtra State Chapter ISA for 3 terms, past presidents ISA Mumbai, Member Specialist Board NBE, Fellowship awarded by ICA, Har Gobind Fellowship to train in cardiac anesthesiologist at Pennsylvania, more than 12 book chapters, a very well-known figure in this field, couple of awards. It's a pleasure to have you, ma'am, on board, and we invite you to chair the session on this important topic of complications in regional anesthesia. Ma'am, can we hear from you?
I think she has not joined as yet.
Okay. So no issues. I'll introduce our speaker of the evening for the master class. It's my pleasure to invite Dr. Parul Jindal, Professor of Anesthesiology in HIMSS, SRHU, Dehradun. Area of interest includes difficult airway, pediatric anesthesia, and postgraduate teaching. Her major achievements includes ISA National Governing Council member 2025 to be till 2028, RACCP National Governing Council member 2024 to 2026. Couple of awards at national level, won the ISA President Appreciation Award 2024, won ISA Proficiency Award in 2023, won Diligent Award in 2022 by ISA, second prize by ISA for raising calls awareness, organized couple of conferences including UVA ISACon 2024 and UK ISACon 2024, and couple of ISA sponsored CMEs. Good number of publications in both national and international journals with citations almost reaching up to 900. She carries herself with vast experience, and I'm sure she would do justice to the topic. Welcome, Dr. Parul Jindal, madam.
Thank you so much, Ankur. Could you please allow me to share my slides?
Yeah. Yeah, the slides are visible.
The slides are visible. Thank you
Yeah.
so much. And good evening, everyone. I'm Dr. Parul Jindal. At the outset, I would like to thank President Sir, Dr. Naveen Malhotra Sir, and Dr. Rajiv Gupta Sir for showing so much of trust in me and thinking I can do justice to this vast topic. I bring you warm greetings from my beautiful state, Uttarakhand. I'm working at Himalayan Institute of Medical Sciences, Dehradun. And my topic today is adverse effects and complications of central neuraxial blockage. Now, why this topic is very important is one, you can get a long question in that. You can get short notes on various topics, subtopics in this. And then it is a very important topic both for your Viva, table Viva, as well as grand Viva. So without wasting much time, I will not discuss what is spinal, what is epidural, what are indication, contraindications, but I'll jump straight into the adverse effects and complications. So the first complication occurred on 16th August 1898. Now this date is very historic because the first spinal anesthesia was given, the first complication occurred, and first reporting of spinal anesthesia also occurred on this date. Sir Carl August Bayer was administered spinal anesthesia by his friend, Dr. Hilbrand, and after the spinal anesthesia, when they tested it by putting the testes, by giving a knee hammering the knee. So he said, after 24 hours, he had a feeling of very strong pressure on the skull and became rather dizzy when he stood up rapidly from the chair. All these symptoms vanished at once when I lay down flat, but returned when I stood up. I was forced to take to bed and remain there for 9 days because all the manifestations recurred as soon as I got up. The symptoms finally resolved 9 days after the lumbar puncture. So there was a big study, which is a multicentric study, which was conducted in Maharashtra on 92,516 patients at 141 centers, in which these patients were given central neuraxial block, either spinal or epidural, and only 8 complications, severe complications, were observed in these patients, where out of 5 patients who had a cardiac arrest on table, 2 were revived, while 3 they were not successful in reviving these patients. So we'll start with how the procedure is done and complications related to needle or catheter introduction. First, it could lead to trauma. because direct mechanical injury to ligaments or bones, bleeding, vascular damage potentially leading to spinal hematoma, infection introducing the bacteria into sterile spinal spaces, unintentional displacement of needle or catheter, or migration or shearing or retention of the catheter. So these are some of the pictures of broken needles and catheters. If you see this picture here, the tip of the catheter is missing, the blue part is missing. So what happens if there is a catheter breakdown has taken place? You leave the proximal part of the catheter there and take out the distal part, and this will help you to guide further in removing. Or if the catheter, the proximal and distal part both have been removed, then what you can do is at the point of entry, insert another needle so that it acts as a guide wire, it acts as a guide to you. So this is an algorithm which is given for a decision about decision tool for foreign body and spine. So if there is a broken spine catheter or a needle, inform the patient and the treating specialist. Do a thorough neurological and physical examination. If there are no abnormal neurological symptoms, obtain a neurological consultation. But if there is a normal physical examination, proceed with scheduled surgery under spinal or general anesthesia if it is an emergency. If it is not an emergency, immediately make the patient prone, and under the fluoroscopic guidance, try to remove the part which is there. So make the plan to remove the needle if it is an emergency and you have to proceed with the surgery. Make plan to remove the needle as soon as possible using the medical imaging. Re-examine the patient after the needle is removed. Report the broken needle or catheter to regulatory authority. In general, preserve the damaged good. Note down the batch number and the product specifications. So direction of the needle. In case if the needle is inserted in the midline or a paramedian approach, it may directly traumatize the spinal cord, whereas an unintentional lateral deviation, as shown in this figure, the C needle, it might injure the spinal nerve or alter anterior or posterior primary ramus outside the foramen. But if it is an intentional lateral approach, for example, in a transforaminal approach, you have the complications may be, it may come in close proximity to the spinal nerve or the spinal artery. So the direction of the needle can also cause an injury. Now, these are some of the case reports which have been there about conus medullaris and cauda equina syndrome. So conus medullaris is the tapered cone-shaped structure, which is the lower end of the spinal cord, while the filum terminal is a delicate fibrous structure which extends downwards from the cone to anchor the spinal cord to the tailbone. The cauda equina is basically the bundle of long free-floating nerve roots which extends downward from the spinal cord, from this resembling a horse tail or a cauda equina. Now, if these structures are compressed, it may lead to conus medullaris syndrome, and the anatomical structure here is the spinal cord at the terminal end. The vertebral level is L1 to L2, whereas at the cauda equina syndrome, it is a bundle of the nerve roots which are compressed below L2 down to the sacrum. The onset of symptoms is sudden and abrupt in conus medullaris, while it is gradual and progressive in cauda equina. There is characteristically bilateral symmetrical, whereas in cauda equina, it is unilateral and asymmetrical. The pain is mild to localized with early onset of bowel and bladder issues in conus medullaris, while the pain could be severe, radiating radicular, and late onset of urinary retention in cauda equina syndrome. The sensory loss is perianal numbness, which is seen in conus medullaris, and a saddle anesthesia, which is seen in cauda equina syndrome. The reflexes like the knee jerk is preserved while ankle jerk is absent, but both knee jerk and ankle jerk are absent in cauda equina syndrome. Now, second is the failure of the block. If you've given a block, maybe the effect is not there. It could be because of three reasons: the operator-related failure, that you've not taken adequate drug dose or volume, improper assessment of the block is there, inappropriate positioning of the patient was there, failure to counsel and communicate to the patient, and seniority and personal experience. The technique-related failure could be a faulty technique, difficult back like anatomical deformities, obesity, misplaced injectate, or pseudopuncture. Equipment or drug-related failures could be blocked needles, use of pencil point needles, drug potency, wrong drug, and drug resistance. Now, there are two types of block. One is a complete failure when there is no sensory or motor effect at all. Here, you have to repeat the block or use the full dose of local anesthetics. Partial failure could be because of the inadequate level, patchy or unilateral block. you can repeat the block, but the dose is now reduced to 25 to 30%. And you can consider combined spinal epidural technique or placing an epidural catheter. So there are three options in case of a failed spinal. One is to repeat the block. The second is to revive the block. And third is to resort to general anesthesia. That is the 3 R's which can be there. So in case if there is a failed block and before giving a skin incision, you can do some maneuvers like putting the head in a low position, left lateral position with the head down, limited hip flexion, ask the patient to perform a Valsalva maneuver or coughing. Epidural volume expansion can be done with saline or local anesthetics if the epidural catheter is in place. In case if the skin incision has been given and then the patient complains of pain, you can start giving systemic analgesic. Local anesthesia infiltration can be done, general anesthesia, and all the more important is to reassure and communicate with the patient. So there are 5, there's a mnemonic to remember how to handle the failed block, that is A, B, C, D, E. A is to avoid excessive and multimodal sedation as the patient might have a compromised airway. Be prepared to accept the failure and consider what are the safe options to proceed. Communicate, listen to the complaints of the pain and discomfort. Stop the surgery, provide reassurance, discuss various options to proceed. Document assessment and level of block, every attempt to revive the block. Explain, give an honest explanation and information to the patient and probable reason why it has failed, what will be the future implications, and have a complete documentation of the whole scenario. Now what happens? Let's see how do we handle it. You've given spinal anesthesia. The patient complains of pain. You stop and reassure and reassess what has happened. Evaluate your situation. Has the skin incision taken place? If the skin incision has not taken place and there is more than 30 minutes have passed, you can repeat the spinal. If it is before incision, less than 30 minutes has passed, you can revive by giving 25 to 30% of the drug. After incision and more than 30 minutes have passed, you can revive by giving the dose, or you can give systemic analgesic or local anesthetic infiltration. If it is less than 30 minutes have passed and incision has taken, you can convert it into general anesthesia. So there are some of the exaggerated physiological responses after giving a spinal or an epidural, that is vasovagal syncope, hypotension, apnea, nausea and vomiting, pruritus, high spinal, total spinal, subdural injection, urinary retention, and backache. So let's discuss a case scenario. There is a 35-year-old primary gravida who was scheduled for LSCS for cephalopelvic disproportion. There is no relevant medical history. Her height is 1.58 meters, weight is 85 kgs. She was given a subarachnoid with 2.2 ml of heavy bupivacaine 0.5% and 20 microgram of fentanyl. Immediately following the block, the patient was put in the supine position with a left lateral tilt. About 5 minutes later, the patient complained of nausea and not feeling well and experienced progressive difficulty in breathing. So the BP was at this time recorded to be 65 by 40 millimeter of mercury. Heart rate was 40 and there's tingling in the fingers. So can you tell me what is the diagnosis? You can just write it in the chat box. And I would request Dr. Ankur to tell me what is the answer by most of our delegates.
Yeah, certainly. I would let you know, ma'am.
So kindly write what is your diagnosis. It's a high spinal. Can we have more answers?
High spinal, vasovagal.
Okay. So let's wait for a couple of more answers and then I'll proceed.
High spinal.
Right. So we have a lot of high spinals going on. So let's consider what was the situation in this case. First, my patient is a pregnant patient. She has a raised intra-abdominal pressure, diminished volume of the lumbar spinal canal, which is caused by distension of the epidural veins. The patient says that she's not feeling well. So the patient often complains of nausea, not feeling well. There's tingling in the fingers, which indicates that there is a high block at the level of T1 or C5 to T1. There's hypotension because there is a venous and arterial vasodilatation, resulting in reduced venous return, cardiac output, and SVR. The bradycardia could be because of the widespread sympathetic block leading to unopposed vagal tone and blockage of cardioaccelerator fibers arising from T1, T4. This may also result as a result of fall in right atrial pressure, filling. So what I did was I gave 100% oxygen to the patient, volume was infused, ephedrine 30 milligram was given. However, she remained hypotensive despite giving 30 milligram of ephedrine, and her condition continued to deteriorate. So you have to consider whether the patient is going to lose consciousness, there's pupillary dilatation, there's a risk of aspiration, and severe reduction in placental blood flow. So the diagnosis was correct. It is a high or a total spinal anesthesia. The causes could be spinal anesthesia when attempting an epidural anesthesia, overdose of local anesthetics, positioning error, or a dose which is not more than required. So what happens is once you've given a block, it ascends upward, and if it blocks T1 to T4 fibers, then the cardioaccelerator fibers are inhibited and there is a vagal predominance. So there's no direct effect on the cardiac inotropy, but cardiac functions can be impaired due to hypoxemia and hypocarbia. Now, if it ascends further, like it is affecting CA to T1, there is a weak hand grip strength by the patient. If it ascends further to C5, C6, there's an upper limb weakness and dyspnea. And there might be impairment of respiratory mechanics now. If it ascends to the upper cervical, that is the phrenic nerve paralysis takes place, it causes marked impairment of the respiratory function. The cervical blockade impairs the sternocleidomastoid and the scalenus muscle, which are the accessory muscles for respiration. Now it ascends further. There's a direct effect on the brainstem function, causing cranial nerve dysfunction, slurred speech, apnea, and vagal inhibition. So how do you manage spinal or total spinal? First and foremost, call for help. Immediate management, stop the epidural infusion if there is some infusion going on. Give 100% oxygen. Consider placing the patient in a head-up position, that is reverse Tenderberg. Reassure the patients and relatives. Assess the patient for airway, breathing, circulation, and disability. In case if airway and breathing is compromised and the patient is unconscious, if it is an obstetric patient, intubate and ventilate, keeping in mind the rapid sequence induction and cricoid pressure. Induction agents are still necessary, but you have to give a reduced dose. In case if it is a failed intubation, then we move over to the failed intubation drill. Now, if there is a circulation compromised, place the patient in a left lateral tilt or manual uterine displacement. Ensure large bore IV cannulas. For bradycardia, you need to give atropine 500 microgram. For hypertension, we give rapid IV bolus and vasopressors as indicated. Now, in case if it is a maternal collapse, is the baby compromised? If the baby is compromised, we go for emergency LSCS. If not, then we liaise with the senior obstetrician. Now, what happens with this high spinal? It lasts for the duration of block will last as per the dose you have given. So subarachnoid block usually recede after 1 to 2 hours, but epidural dose delivered into intrathecal will take several hours. So you need to ventilate the patient at this time. Now, what happens is that the patient recovers from the consciousness before being able to breathe effectively. So some sedation is required. And once the patient has a good cough reflex or is able to generate good tidal volume, the patient is extubated. So let's take another case scenario. There is a 28-year-old patient who develops sudden unconsciousness following labor analgesia administered. And once she becomes unconscious, the patient is taken for emergency LSCS because the neonatus has shown signs of fetal bradycardia, post-epidural, after the epidural was given, and requires intensive care. The mother has a complete recovery after some time, and there's no postpartum complications. So may I know what is your diagnosis and what do you think it is? Please write in the chat box whatever you feel is the cause.
I request all the delegates to kindly put forth your answers. Let's see.
Okay, so let's. Yes,
Okay.
right.
Intrathecal spread of drug.
Yes, so let's discuss this further. What happens here is that you are in the epidural space, you've put your epidural needle there, there's no loss of CSF, but at some point, the drug, because of the CSF pressure, it percolates into the subdural space. There has been an accidental puncture of the dura, but still the needle is not into the CSF. So it is an unusually high sensory block which develops very slowly even after 20 minutes. The motor blockade is very less. The clinical picture is moderate hypotonia, breathing difficulties with retained consciousness, and often involvement of cranial and cervical nerves. Trigeminal nerve palsy with simultaneous Horner syndrome, which is marked by anhidrosis, meiosis, and ptosis, is there. So, because this is a very complex diagnosis, you need to have some methodology to understand it. So, there are two diagnostic models. One is by Lyubimov, which says that there is a negative CSF test. There's unusually an extensive sensory block. There's a delayed motor block. There's inconsistent motor blockage and disproportionate loss of sympathetic tone. Now, along with this Lyubimov diagnostic model, if we have neurological symptoms like incorporating your Derbatom evaluations, how slowly the motor blockade has occurred, the cardiovascular consistency, uneven distribution, and Horner syndrome, we have a diagnosis of subdural block. So subdural block, as compared to high spinal, is delayed and gradual. The sensory block is high, often patchy and asymmetrical, whereas in high spinal, the sensory block is strictly symmetrical. The motor block is mild or entirely spared, but in high spinal, it is profound and complete. There's mild hypotension or bradycardia in subdural, while cardiovascular collapse is present in a high spinal block. Respiratory failure is rare, but it is common. So here the diagnosis is because of the stable BP. It often points to a subdural block. Now there's another case we have here. This is a 39-year-old pregnant patient, 38 weeks of gestation with episodes of non-sustained ventricular arrhythmia and newly developed vasovagal syncope during pregnancy. And this patient was scheduled to undergo subarachnoid block for an elective LSCS. A sudden severe bradycardia followed by cardiac arrest occurs. The patient fully recovers after prompt CPR with chest compression, manual ventilation with oxygen, rapid injection of epinephrine, and hydration. So this is actually the case report which has been published. So what do you think was the diagnosis here? Can we have your answers in the chat box?
No answers as of yet.
Okay, so Ankur, what do you think?
Could be intrathecal administration.
Could be intrathecal or it could be a vasovagal syncope.
Vasovagal syncope. Yeah.
Yeah, because there is a lowering of blood pressure to a point where coronary arteries are not adequately perfused. And this causes hypoxia to the vital centers, progressive upper paralysis of respiratory mechanism, and occasional toxic absorption of drug. So why this scenario occurred? Let's discuss it with this diagram. We have a patient who already has a history of vasovagal responses. Now, she has a history of vasovagal response. During pregnancy, her systemic vascular resistance is decreased. There's aortocaval compression. There's a high neuraxial blockade is there. And what are the other triggers for the vasovagal response? It could be the emotional effect. She's about to become a mother. She could be nervous, anxious. There could be a sudden hemorrhage, which could decrease the venous return. There is uterine manipulation, which has an increased vagal tone and decreases the heart rate. So all these things, when combined together, can lead to vasovagal cardiac arrest, which happened in this particular case. So the treatment is to make the patient supine, except in the advanced pregnancy where you have or abdominal tumors where a bolster is placed under the right flank. Tilt the patient's head down and elevate the legs. Give 100% oxygen. Give IV fluids, vasopressor drugs if required, and cardiac massage if there is no evidence of cardiac action. Now, there's a 40-year-old man following spinal anesthesia prior to a planned abdominal surgery. So after giving a spinal anesthesia, this is the ECG which was noted. This is the rate which has now observed, whereas previously he had normal rate. So what do you think has happened? Okay. Can you write it in the chat box? What do you think? We have some answers like bradycardia.
Vasovagal, high spinal.
So this here, what has happened is a sinus bradycardia. Now, why do we say it's a sinus bradycardia? Because there is vasodilatation which leads to venous pooling, and fall in systemic vascular resistance. Now, this reduced venous return may stimulate the intrinsic cardiac reflexes, including the BJR, that is the basal Jurix reflex, which increases the stimulation of the ventricular mechanoreceptors. Now, these ventricular mechanoreceptors, as the name suggests, are located in the inferior posterior wall of the left ventricle. And when these experience extreme stimulation, they can send signals via unmyelinated vagal afferent C fibers to the central nervous system. And this triggers a powerful autonomic tone, the parasympathetic activity, which increases dramatically while sympathetic output is suppressed, resulting into a classical triad of bradycardia, hypotension, and peripheral vasodilatation. The second is the Bainbridge reflex. In the classical Bainbridge, because of the blood returning to the heart, there is the blood is returning to the heart, the atria is overfilled, and there is the heart rate will increase. Whereas in the reverse Bainbridge reflex, because of the vasodilatation, the venous pooling has taken place, the venous return decreases, and there is decreased stimulation of the atrial stretch receptors, and they send a signal via the vagus nerve to the nucleus tractus solitarius in the brainstem. And because of this, there is a lowering of the sympathetic drive of the SA node. The third part is the pacemaker stretch reflex. There is a decreased stimulation of the pacemaker cells at the sinoatrial node, which confirms the structural shape and reduces the open probability of the ion channels. So because of this, this promotes the bradycardia. Now, the second part which comes is the hypotension, which there are several theories as to why hypotension occurs after spinal anesthesia. It is because of the diminished cardiac output consequent to the reduction of venous return to heart and lack of muscular propulsive forces in the veins. It could be because of the dilatation of the post-arterial capillaries and small venules due to paralysis of vasoconstrictors. This paralysis of the sympathetic nerve supply to the heart. There's paralysis of the sympathetic nerve supply to the adrenaline glands with subsequent catecholamine release. Absorption of drug into the circulation, ischemia and hypoxia of the vital organs, hypovolemia, and compression of great vessels within the abdomen. So all these can result into hypertension, and our aim is to increase the venous return to the heart and raise the cardiac output. So you can give volume by giving by giving balanced all solutions to the tune of 10 to 15 ml per kg, give 100% oxygen, raise the heads. Trendelenburg position can be given because it will not affect the spread of the anesthetic significantly. Atropine if there is a bradycardia, and small IV doses of vasopressor may also be needed. What you can do, how to prevent this is to, in pregnant patient, in older patients and obese patients, reduce the dose of local anesthetics, and opioids or a combination of these drugs, if given, have to be reduced. Prophylactic administration of vasopressor is not recommended. Now, some patients may experience nausea and vomiting following hypotension, hypoxia, narcotics in the central neuraxial block, increased peristalsis, and traction of the nerve endings. So the treatment is to reassure the patient and give attention to the general comfort of the patient, correction of the hypotension and hypoxia if it is present, give atropine if there is bradycardia, ask the patient to take deep breath through the mouth, give antiemetics where possible, and if the condition persists, you might have to convert the patient into full G. Now, shivering takes place because of hypothermia, because of vasodilatation and venous pooling and venous return. There is pain the patient might feel. There's cold OT temperatures. The rapid infusion of unwarmed IV solutions, choice of your neuraxial technique, and use of oxytocin and intrathecal morphine. Now, what are the gradings of shivering? There's 0 grade, which is no shivering. Grade 1 has one of the following, like piloerection, peripheral vasoconstriction, peripheral cyanosis with no other cause, and but no muscle activity is there. In grade 2, there is a visible muscular activity, which is always often confined to one muscle group. In grade 3, there is a visible muscular activity in more than one muscles. And in grade 4, there is a gross muscular activity involving the whole body. So for post-operative shivering, we have to first prevent it by using non-pharmacological methods like giving warm IV solutions, giving passive warming by using cotton blankets or gown warming. Pharmacological prevention can be either by giving magnesium sulfate 25 milligram per kg IV or dexamethasone 4 milligram, or ketamine 0.25 milligram per kg IV. Now, management of shivering, this was about prevention. Now we have to manage it. Now, management depends upon the grade of shivering, as I've told you. In grade 1 shivering, we can use cotton blankets, gown warming, warm IV infusion, plus ketamine 0.25 milligram per kg IV. If the patient proceeds and these effects are not there, it have taken place, then the grade 2 shivering is there, and we can supplement magnesium sulfate 50 milligram per kg IV along with the upper interventions. Even this fails, the patient has now progressed to grade 3 shivering. You can give magnesium sulfate 50 milligram per kg IV plus 0.2 milligram per kg per hour as infusion, or you can administer tramadol 0.5 milligram per kg IV. Even if this intervention fails and now the patient has grade 4 shivering, we can give tramadol 1 milligram per kg IV again. And if shivering persists, then consider giving pethidine 0.5 milligram per kg. Now, pruritus. It can occur in spinal root in 46% patients, in epidural 8.5% patients. The severity of pruritus is proportional to the intrathecal morphine or opioid, but it does not depend upon the epidural dose. It is distributed around the face and nose, although symptoms may not be mediated by opioid receptors. So it can be treated with opioid receptor antagonists like naloxone. There are reports of ondansetron being used for opioid-induced pruritus. Some of the patients may complain of urinary retention. If the neuraxial blockade blocks the S2 to S4 nerve roots, it decreases the urinary bladder tone and inhibits the voiding reflex. Long-acting local anesthetic agents require longer time for the bladder functions to recover. The spinal opioids also influence the bladder function and cause urinary retention. There have been few cases of transient low-frequency hearing loss, especially in the elderly patients. This is because of the decreased CSF pressure on inner eardrum. The risk of hearing loss is lower with smaller gauge and needles as compared to broader gauge, and they resolve in about 1 month. So these are some of the case reports which have cases which have been reported about the sudden sensorineural hearing loss after surgery. Now, what is the effect on the fetus and the newborn? The local anesthetics do not have neonatal depression, especially the cardiovascular, respiratory, or neurological. There is a temporal relationship between the spread of the onset of local labor analgesia and appearance of fetal bradycardia. In case of a spinal analgesia, fetal bradycardia can occur in within 10 minutes, and in epidural analgesia, it can occur in 15 to 30 minutes. The cause could be maternal hypotension, uterine hyperactivity, and increased uterine tone. The clinical implications are not clear because of this fetal heart rate changes in response to labor analgesia, there has not been a rise in the rate of intervention deliveries like forceps delivery or LSCS. The possible mechanism for increased uterine tone is thought to be related to an imbalance between the circulating catecholamines secondary to analgesia and favoring the alpha over the beta activation of smooth muscle receptors. The hypertonic uterus and fetal bradycardia are usually short-lived, although they can be relieved by administering nitroglycerin or beta-2 agonist. Allergic reactions to local anesthetics, preservatives, or additives. The ester type of local anesthetics, due to their metabolism to the well-known allergen para-aminobenzoic acid, are more prone for allergic reactions. The preservative methylparabene, which also metabolized to para-aminobenzoic acid and should not be present in local anesthetic preparations intended for spinal injections. Allergies to amide local anesthetics are rare. So let's take a case scenario, and I would request you all to write what is your answer. A 68-year-old male weighing 52 kgs receives a retrovalvular block. I've not taken a central neuraxial, just to make it more clear, with 25 ml of 0.5% bupivacaine. After 3 minutes, the patient complains of dizziness. His speech is slurred and he becomes restless. So what is your provisional diagnosis? May we have the answers in the chat box?
Two of the delegates have mentioned local anesthetic systemic toxicity.
Excellent. So without wasting much time, let's proceed to that. So, as Sir said, I should point out what are the preventions. So prevention is by using ultrasound, which reduces the risk of loss by 60 to 65% as compared to peripheral nerve stimulation alone. Increase the accuracy of delivery permits reduction in volume and dose of local anesthetics. The incidence of vascular puncture may be reduced. Using epinephrine can also, tell you whether you are into a vascular space, because it will cause a rise in blood pressure as well as a rise in heart rate. So, remember the doses. Remember what is the maximum dose you can use with epinephrine and plain. Like for bupivacaine, the maximum dose which we can use is 2 milligram per kg plain. With epinephrine, it is 3 milligram per kg. Levobupivacaine, it is 2 milligram per kg, 200 milligram. And with epinephrine, it is 3 milligram per kg. Lignocaine is 5 milligram per kg plain and 7 milligram per kg with epinephrine. Ropivacaine is 3 milligram per kg with epinephrine, without epinephrine. So whenever you're giving a block, then give local anesthetics in small aliquots of about less than 5 ml, pause for 30 to 45 seconds, and then give more drug. The epinephrine may, as I've said, may also mitigate the risk of intravascular because it causes a rise in heart rate and blood pressure. Clearly label all your syringes and transition from Luer connectors to small bore connectors. To prevent, select your patient appropriately, select what is the nerve block you're giving, select the drug and the dose accurately, give 100% oxygen to the patient, continue with standard monitoring, start an IV access. Monitoring should continue for at least 30 minutes after the completion of the injection, as delayed presentations are increasingly occurring. Raising awareness and educating our non-anesthetic colleagues by telling them what is the proper use of local anesthetics, including the management of last, and start practicing on simulation-based scenarios. This is a last rescue kit which has around 4 bags of 250 ml of 20% lipid emulsions, 3-way lock system, 50 ml of Luer lock syringes for rapid infusion of lipid emulsions, infusions equipments, and venous access devices of different diameters. Now, this is the algorithm which has been given by NISORA for local anesthetic systemic toxicity. They say that you call for help immediately, start with the life support ventilation if it is required, and in case if the patient has seizures. Now, roughly half of the cases of LAST are atypical with no seizure or other CNS symptoms, only cardiovascular toxicity or delayed onset. But in case if there is a seizure, start midazolam. In the life support, initiate the cardiovascular life support protocol, alert the nearest cardio bypass facility which is there. Lipid emulsion can be started at the bolus of 1.5 ml per kg, and infusion can be started at 0.25 ml per kg. Now you assess the patient. If the patient is cardiovascular unstable, still cardiovascular instability is present, then repeat the dose of 1.5 ml per kg. If hypertension is present, double infusion of 0.5 ml per kg. So continue the infusion and monitor the patient for 12 hours. Now this is the guidelines which have been given by ASRA. In this, the lipid emulsion of 20%, they have quantified it according to the weight of the patient. If the patient's weight is more than 70 kg, you can clearly give a bolus of 100 ml over 2 to 3 minutes and infuse 250 ml over 15 to 20 minutes. And if the patient still remains unstable, repeat the bolus or double the infusion. If the patient's weight is less than 70 kgs, we give a bolus of 1.5 ml per kg over 2 to 3 minutes and infuse 0.25 ml per kg per minute. Consider using a pump if the patient's weight is less than 40 kg. Now, if the patient remains unstable, either repeat the bolus dose or double the infusion. Now, observe the patient. Is the patient having arrhythmias or hypotension? So, if the patient has hypertension, arrhythmias, we have to remember that the resuscitation with LAS is different from the standard ACLS. The epinephrine dose here is given is small, and it is given as less than 1 microgram per kg. Avoid local anesthetics, beta blockers, calcium channel blockers, and vasopressin. If the patient is stable, continue lipid emulsions for more than 15 minutes. Once hemodynamically stable, the maximum dose of lipid dose can be given is 12 ml per kg. Once the patient is stable, observe 2 hours after seizures and 4 to 6 hours after cardiovascular instability. In case if the patient has seizures, ensure that the airway is maintained. Benzodiazepines are preferred, but if they are not available, even propofol 20 milligram increments can be given. So let's start with another case scenario. We have a 28-year-old G3P2 at 40 weeks of gestation. The subarachnoid block was given at L3, L4 for LSCS with 23 gauge Quincke's needle. 2.2 ml of 0.5% heavy bupivacaine after clear flow, free flow of CSF was given. On post-operative day 3, the patient complains of throbbing occipital headache, 5 to 6 VAS score in severity and aggravated with patient in head-up position. There's no neurological deficit, nausea and dizziness is present. So I don't think there is any confusion what we are dealing with here. Still, it is post-dural puncture headache. So up to 20% of the patients and up to 75% of the patients, when a large bore needle is used, complain of post-dural puncture headache. The onset is usually within first 5 days or 3 to 5 days. It usually worsens when the patient sits or stands. It is often occipital and associated with pain and neck stiffness in neck and orbital area. Sicard suggested that it could be because of the leak of CSF into the epidural space, and the average loss of the CSF is about 10 ml per hour. The healing, according to the radioisotope myelography, may take around 3 weeks, and headache may last up to days to weeks, but usually they end by 2 weeks. Now, there are two theories of the cause. The one is the low CSF pressure. There is a dural rent. There is continuous CSF leak more than the production of CSF. There's traction on the pain-sensitive structures, which lead to headache, and traction on the cranial nerves, which leads to tinnitus and diplopia. There's traction on the blood vessels, which leads to cortical venous thrombosis. And in the high CSF pressure, this is due to the meningeal irritation due to bacterial or chemical invasion. So diagnostic feature, how do we differentiate between a low pressure CSF, that is a classic PDPH, or a high pressure CSF? When the patient lies supine, he feels immediate relief within 15 seconds, 15 minutes, and in a high pressure CSF, it worsens or stays severe. When the patient stands upright, there is a severe throbbing pain like headache in low pressure CSF, and in high pressure, it improves or stays stable. On giving abdominal compression, it eases the headache, but it might worsen the headache in high pressure. When a patient performs a Valsalva or a coughing, there's little change in pain, but it is severe and sharp like in case of high pressure. During the afternoon or evening, the headache worsens, while it is in the early mornings on waking up that the patient feels headache in high pressure. If you do an eye examination, there's normal optic nerve in low pressure CSF, but there might be papillary edema or swollen nerve in the high pressure. So what happens in PDPH? The frontal headache is because of the involvement of the ophthalmic branch of trigeminal nerve. The occipital, the neck and the shoulder pain is because of the servo-trigeminal pathway involvement of C1 to C3. Gastrointestinal symptoms like nausea, vomiting could be because of the vagus nerve involvement. Visual disturbances is extraocular nerve traction, cranial nerves 6, 3rd and 4th. Auditory and vestibular symptoms could be cochlear pathways and vasodilation of intracranial vessels. Now, there are two types of needles which we have. We have pencil point needles and we have cutting edge needles like Quinky. So, these are the procedural characteristics which are associated with PDPH. There is a very strong reporting, and there is a strong evidence that there is using cutting needles. Compared with cutting needles, the non-cutting needles are associated with decreased PDPH. Needle size, the narrow gauge needle reduces the risk of PDPH. The needle advancement is that there is evidence is insufficient to confirm benefit of any technique used to identify the epidural space or reduction of the incidence of PDPH. More the number of attempts, the higher is the risk of PDPH. More experience the operator, less is the incidence of PDPH. Level of neuraxial block does not have any association with PDPH. Patient's position, they advise that the lower the risk of PDPH in patients in whom the block was performed in the lateral decubitus position. There is no evidence to suggest about the traumatic or atraumatic tap. Now, the postpartum headaches could be because of migraine tension type. So you have to differentiate it with the PDPH. Now, when do we say it is a PDPH? When the patient has a history of spinal or epidural procedure within 5 days of the headache, starting of headache. When the patient, the symptoms will worsen within 15 minutes after sitting or standing, and they are relieved within 15 minutes of lying down. When the patient has a headache, which is accompanied by at least one of these symptoms like neck stiffness, tinnitus, hyperacusia, photophobia, and nausea. So now we've made a diagnosis that the patient has PDPH. We first go for the conservative management. Like we give psychological support to the patient. We advise strict bed rest, frequent long drinks, a tight abdominal binder, a continuous drip of Hartmann solution, simple analgesics, and caffeine. And we observe the patient for 24 hours. If the NRS is less than 3, so we continue with the conservative measures. But if it is not relieved, the patient is not relieved, we go for a sphenopalatine ganglion block. So if the symptoms are again relieved within 24 hours and or the NRS is less than 3, we continue with the conservative management and watch for any recurrence. But if there is no relief to the patient, then we give him or her an epidural blood patch. So there is a relief of symptoms within 2 hours and NRS is 3 or less. But if there is no relief, then we go for a repeat epidural blood patch. So these are some of the drugs which can be used for relief of PDPH pain. The one is methylxanthine. These are the group of derivatives of xanthine which act on the adenosine receptors. These are not selectively antagonists and lead to vasoconstriction, which negate the compensatory cerebral vasodilatation. They activate the sodium-potassium pump that are involved in the regulation of CSF production. One of the drugs is caffeine, which causes cerebral vasoconstriction. Oral, the dose is 300 to 500 milligram OD or BD. Do not exceed more than 900 milligram. IV, it can be given as 0.5 gram IV. Sumatriptan, it is a serotonin receptor agonist and a cerebral vasoconstrictor. Though the response to this drug is still inconclusive, it can be administered 50 milligram 8 hourly for 5 days. Gabapentin and pregabalin, they modulate the presynaptic NMD receptors at the level of spinal cord or inhibit the sympathetic pathway of pain. Gabapentin is given 200 milligram initially, which is followed by 300 milligram 3 times a day. Pregabalin is 75 milligrams BD for 2 days and then 150 milligram BD for 2 days. Corticosteroids like adrenocorticotropic hormone, they interact with the opioid receptors in vitro and have morphine-like effects. They increase the brain beta endorphins. They stimulate the adrenal cortex, which is responsible for anti-inflammatory and water retention. The dose is 1.5 microgram per kg, but still the results are inconclusive. You ask the patient to take a deep breath. Now, because of taking a deep breath, after that, you squeeze the chest and the abdomen and hold for 10 seconds. This increases the transthoracic pressure and transabdominal pressure. The abdominal pressure causes the thoracic and the abdominal veins to empty into the valveless epidural vein. And the pressure is transmitted to the epidural space. So this causes a tamponade-like effect due to the related epidural pressure. And this causes the relief in headache. Another technique which can be used is the sphenopalatine block. This is a triangular shaped parasympathetic ganglion which is located superficially in the pterygopalatine fossa, posterior to the middle nasal turbinate and anterior to the pterygoid canal. This is called as the pterygopalatine Meckel's or nasal ganglion. It is 5 millimeter in size and has about 1 to 1.5 millimeter thick layer of connective tissue and mucous membrane surrounding the ganglion. So the drug enters well by topical application. You can go through the transnasal, transoral or transygomatic approach, but transnasal is totally non-invasive, so it is preferred. You just take a long cotton-tipped applicator soaked in 2% of lignocaine. After 5 minutes, it is you keep it compressed with a cotton swab for 5 minutes, and after that, it is repeated on the other side. The other is a greater occipital nerve block. This is a supply of C2 to C3. And you can identify by the surface marking, like just below 3 to 3.5 centimeters below the occipital protuberance. You draw an imaginary line between the occipital protuberance and the mastoid process. Occipital protuberance is also called as inion. And 1.5 centimeter on either side, you can give the drug. So, or with the help of an ultrasound, the ultrasound is placed at this point that is around 3.5 centimeters below the greater occipital protuberance. And 4 ml of 0.25% bupivacaine can be administered. So in the next resort is epidural blood patch. It is a gold standard for treatment of PDPH. The success is about 61 to 98%. Here, the sterile injection of fresh autologous blood is given near the previous dural puncture. The mechanism of action is it decreases or stops the further CSF leak. by formation of a clot over the defect in the meninges. This causes a tamponade effect with syphilid displacement of CSF. So the technique is you first need to take a written informed consent from the patient, establish an IV line, position the patient for epidural. Lateral decubitus position may be more comfortable than sitting. Place the epidural needle into the epidural space at or below the level of the previous meningeal puncture. Collect 20 ml of fresh autologous venous blood using a sterile technique, and without any delay, inject the collected blood through the epidural needle until the patient reports fullness or discomfort in the back, buttocks, or neck, whichever comes first. Maintain the patient in the recumbent position for 1 to 2 hours. IV infusion of 1 liter crystalloids may be helpful for headache until EBP starts working. So after the instruction, encourage over-the-counter analgesics like paracetamol, ibuprofen, prescribe stool softeners or cough suppressants, avoid lifting, straining, or air travel for 24 hours, provide instructions on how to contact anesthesia personnel. So alternative treatment options to EBP is that you can, apart from blood, epidural saline can be used, usually 20 to 30 ml, repeated if necessary and if a catheter is present. Dextran 40 has been written in literature, but it has a very high incidence of allergic reaction. Hydroxyethyl starch, gelatin, and fibrin glue have been mentioned. Alternative invasive procedures could be a prophylactic epidural blood patch. So up to 20 ml of blood is injected before the catheter is removed. The success rate of prophylactic is not as high as a therapeutic epidural blood patch. It may not even prevent symptoms of PDPH, but it may reduce the length and severity of the symptoms, but it is not often recommended. In case if there is an unintentional dura puncture and the intrathecal catheter placement has taken place, leave the catheter there for 24 hours. The risk of inadvertent epidural dosing of intrathecal catheter and risk of infection should also be considered. Prophylactic intrathecal morphine can be given through the intrathecal catheter. Excessive spread of local anesthetics in the brain causes direct neural toxicity. So downward traction of the brain along with cranial nerves due to low CSF pressure may take place, and sixth cranial nerve is more prone due to its long and tortuous course. The patient may complain of photophobia and diplopia due to lateral rectus muscle paralysis. So the incidence of vertebral canal hematoma, even though it is very rare, it has been reported as 1 in 1,50,000 in epidural and 1 in 2,20,000 for spinal hematoma. Female gender, increased age, traumatic needle and catheter placement. Catheter placement or removal in patients on anticoagulant therapy are high-risk patients for vertebral canal hematoma. It is sudden onset radicular back pain with motor and sensory deficits. Discontinue any epidural infusion. If there is recovery within 4 hours, and it should be progressive, nothing is required, but get a prompt imaging MRI. In case if there is no recovery, then surgical decompression within 8 to 12 hours is suggested. Exclude the diagnosis prior to removing an epidural catheter. Neurological observation for 24 hours after epidural catheter removal and longer if the patient remains immobile. So it is recommended that it is safe to put in, give a central neuraxial blockade if you have a platelet count of about 70 to 80,000 per cubic millimeter. If the count is 50 to 70,000, a more careful assessment, patient-related circumstances should be considered. If around 50,000, then weigh the risk and benefit ratio. It is not only the quantitative assessment of the platelet count, but the qualitative assessment, that is the function of the platelet count and the rate of decline in the gestational thrombocytopenia, idiopathic thrombocytopenia, preeclampsia and sepsis should be taking place. If the patient is obese, has a full stomach, or the patient has a difficult airway, then you have to consider, even if the platelet count is less, you can consider giving a spinal or an epidural. Now, let's take another case scenario. There is a 31-year-old who's been given an epidural anesthesia indicated to relieve the labor pain. After 3 hours, the patient is posted for LSCS for fetal distress. The epidural catheter was then used to relieve the pain for the first 48 hours post-operatively. On day 5, she presented with high grade of fever, 39 to 40 degrees Celsius, fatigue, dyspnea, and lumbar pain. The patient then suffered from sepsis and lower limb paralysis. So what do you think is the diagnosis? Can we have the answers in the chat box?
Kindly respond to the queries. Yeah. Meningitis 1, meningitis again, epidural abscess. Has someone hit the nail, ma'am?
Let's see. So this is an epidural abscess, which is based on MRI of the lumbar spine. This was the patient, and this is the epidural abscess. So epidural abscess is keenly has been observed in 62,000 around 63,000 patients, 1 in 63,000 patient in obstetric population. The pathogenesis is because of the hematogenous bacterial seeding of the epidural space from the skin flora, or the most common organism here is Staphylococcus, and the lab findings may reveal a elevated WBC, CSF protein, CSF white cell count. The symptoms a patient may present with is back pain, pyrexia, malaise, sensory changes, flaccid paralysis, and spastic paralysis. The management is to give antibiotic therapy, usually 4 to 6 weeks, and a possible surgical drainage. Antibiotics active against Staphylococcus aureus, including MRSA and anaerobic gram-negative organism, especially in patients with a history of intravenous drug abuse. A suggested triple agent regime is vancomycin, metronidazole, and cefuroxime. So another complication, which is, though there is a very limited evidence in literature, is arachnoiditis, which develops after unintentional injection of chlorhexidine. The patient complains of lower back pain, dysesthesia, and paresthesia. The management is steroids, NSAIDs, gabapentin, local anesthetics, and nerve stimulation. Meningitis has been reported, and the incidence is 1 in 2 lakh population in obstetric anesthesia. Pathogenesis is because of the contaminated equipments or hematogenous seedling of the drug into the spinal space, or droplet infection from the anesthetist himself. Most common microbe is Streptococcus, and the lab findings may have an elevated WBC, CSF proteins, CSF WBCs, and CSF decreased CSF glucose. The patient complains of fever, headache, stiff neck, altered mental confusion, and photophobia. Symptoms usually develop 24 to 48 hours after CNB. The management is to administer antibiotics in patients with bacteremia. Antibiotics should be administered prior to performing a neuraxial blockade and maintain strict sterile technique, and antibiotic prophylaxis can be given. So there's another scenario, that is a transient neurological syndrome. This is a syndrome of pain and dysesthesia in these buttocks, thighs, or calves that can occur following subarachnoid block. They're usually self-limiting and resolved within 72 hours. Lignocaine has been implicated in most of the cases, but bupivacaine has also been found to cause mild TNS. L5 to S1 dermatome most commonly involved, as these nerve roots lie in the most dorsal part of the spinal cord. It is not associated with any neurological pathology. So one important complication here is the anterior spinal cord syndrome, that is called as the Beck syndrome. This is the anterior spinal cord has an artery of Adamquist which arises from the left side between T11 to T12, but it can vary between T8 to L2, and the blockage, like aortic cross clamping or trauma, causes ischemia to the lower portion of the anterior spinal cord, and it may result in the loss of function in the anterior part and cause the Beck syndrome and not the Beck's triad. So the Beck syndrome is, in the anterior part, there will be loss of functions. In the corticospinal tract, there will be flaccid paralysis and lower extremities. There's autonomic motor fibers may be involved, leading to bowel and bladder dysfunction. And spinothalamic tract causes loss of temperature and pain sensation. Because the posterior or the dorsal column is preserved, the touch and the pressure sensations are preserved. So if it is the clinical features which appear within hours will be back or chest pain, flaccid paralysis, paresis or quadriparesis, bilateral loss of temperature and pain sensation, urinary retention, autonomic dysfunction like bradycardia, hypotension, impaired temperature regulation. The patient might develop spinal shock, that is absent bulbocavernous reflex, that is on squeezing the glans penis or pulling on the Foley's catheter while digitally palpating the contraction of the anal sphincters. After days, the patient may experience continued sensory or autonomic dysfunction, spastic paresis or quadriparesis, hyperreflexia, appearance of bilateral Babinski's kind and automatic bladder. Now, rare complication is posterior reversible encephalopathic syndrome, that is PRES, which is a rare neurotoxic condition characterized by swelling in the brain, most commonly affecting the parieto-occipital region at the back of the brain. It presents with sudden neurological symptoms like severe headaches, seizures, visual loss, confusion, and it is usually triggered because of the acute spike in blood pressure or exposure to toxic medications. Normally what happens when the brain, there is a sudden spike in blood pressure, the brain blood vessels, they usually constrict during the high blood pressure and to keep the blood flow stable. But when this blood pressure rises too fast, the system fails and causes hyperperfusion, causing excessive blood flow. The back of the brain has fewer sympathetic nerves to control this and making it more vulnerable. The endothelial dysfunction, because of the certain medications or infection, the damage to the lining of the blood vessels, that is the endothelium, takes place. This causes the protective blood-brain barrier to break down, allowing fluid to leak directly into the brain tissue and causing swelling. So other complications can be central venous thrombosis and cerebral ischemia, which comprises of the catastrophic complication. Cases of this complication following spinal anesthesia have been described, and they have generally a very high mortality. Toxic or infectious encephalomyelitis after spinal anesthesia can cause symptoms which are characterized by neurological deterioration, facial paralysis, cranial nerve 3 paralysis, paraplegia, and cerebral edema. Patients with pre-existing pathology of spinal canal have higher incidence of neurological complications. Lumbar disc injuries increases the risk of neurological complications. So, to conclude that yes, these complications do occur, and they occur even if you give it in combination with GA or you take all the precautions. But the major part is that be careful, be vigilant, and be observant. So these are some of my references I've taken. Thank you so much.
Thank you so much, ma'am. This was an absolutely true masterclass. A full justice to the topic. You have mentioned all the important points pertaining to complications of regional anesthesia. I'm sure the delegates, including me, everyone, we have important take-home messages from this important session. If anyone is having any query, we still have time. You can kindly unmute yourself and put forth your question, or you can put your question in the chat box. Meanwhile, can we take one question, ma'am?
Yes, please.
There was a question by Dr. Rajagopalan.
Yes, sir.
He has asked whether can there be a vasovagal response during subarachnoid block or epidural injection of cold fluids into the space? Can there be vasovagal syncope?
I've seen it, not with the cold fluid, but I've observed it in a 25-year-old male who he was in a sitting position. We were giving him a spinal, and suddenly we observed that he had a bradycardia. The heart rate went down to 35. So immediately we took care. We made him lie down, elevated the legs, gave him 100% oxygen, and the fluid was rushed, and he recovered immediately.
So what could be the reason in such a young male that he's having vasovagal at the time of
We
administration of
forgot to take
spinal?
his history. He was working in gym. He was a bodybuilder. So he already had a controlled heart rate. One thing was there. And secondly, it could be because of the sitting position, which is very uncomfortable to the patient at times.
Yeah.
So that could also be one reason.
Yeah. Well highlighted, ma'am. And probably as cited in literatures, it also says that if you make the patient sitting for prolonged time,
For a long time.
that
Yes.
could potentially reduce the venous return and can cause vasovagal syncope. In addition, the patient may have too much of anxiety, stress. This may lead to vasovagal syncope.
Yes.
So, and in my observation, those with diabetes, uncontrolled diabetes with long-standing neuropathic conditions, they tend to have more of vasovagal syncope. And another question, how will you manage PDPH for a patient with HIV? I think specifically the question is related to epidural blood patch.
I think you have to take all the precautions for that. Rather than that, if first you have to go with the conservative management. If the conservative management does not uh, give you the desired result, you can go with a sphenopalatine nerve block. If the sphenopalatine ganglion block is not effective, then you think of epidural blood patch. See, relieving the symptoms, I think, is more important than taking into consideration the fact that the patient is an HIV patient. You take all the precautions, and we generally give spinal anesthesia or any other maneuver we are doing or any other intervention we are doing for the HIV patients or HCV patients also. So take universal precautions.
And another question is by Dr. Rajagopalan. How common is backache after subarachnoid block? And this is a common persona
Very
in
common.
society that I had my operation, injection was given at my back, and since then onwards, since last 2 years, 3 years, I am having backache. So how do you counsel such patients?
See, one thing is that backache has been reported as much as 40%. Now, that depends upon the number of attempts you've taken, any trauma which has taken place, whether the patient has been recumbent for a very long time, when the patient has been shifted from the OT table to the transport table. So all these things also affect it. It is very self-limiting. It has to be, the patient has to be counseled. Some patients say that they persistently have backache. So we have to tell them that even though it is persistent, this does not affect, or it will not prolong, or it will not aggravate your symptoms further. So it is more about counseling. It is more about educating the patients for backache and educating the surgeons as well.
Okay. Another question is by Dr. Shweta. Is posterior reversible encephalopathy syndrome seen as a complication of subarachnoid block, or it's an independent identity?
It's seen as a complication of spinal. There have been case reports where it has been documented, but it's very rare. It's very rare. I've just covered it because of the, it's, one of the complications which has been documented.
Yeah. Basically, to Dr. Shweta, PRESS is a more of a sequelae of persistent hypertension, right? Where it involves the occipital lobes, typically the occipital lobes, and because of the persistent hypertension, and thereafter patient presents with visual disturbances and probably seizures also, but not that frequent. But because of occipital lobe, visual blurring is a more prominent symptom, and the only treatment is control of blood pressure and reverse the hypertension. Next query is by Dr. Reddy. What is the incidence of transient neurological symptoms in lidocaine and
Incidence of
bupivacaine usage?
PNS, if I remember correctly, it is 0 to 40%. And with lignocaine, the incident might be as high as 10 to 30% because it is the most common drug which causes it. And bupivacaine is around 0 to 3%.
But ma'am, how commonly are we currently using lidocaine? Is anyone
No,
using
at least I'm
lidocaine
not using it.
for
We are not,
spinal anesthesia?
no, we are not using it.
Any delegate who is currently using lidocaine for spinal anesthesia? I guess no one is using lidocaine. And what are the contraindications for PDPH? Dr. Reddy has asked. Contraindications for PDPH. Can you paraphrase your query, Dr. Reddy? I think he means to ask something else.
Is it contraindications of giving before giving epidural?
Possibly. Dr. Reddy, if you are there, can you
Yes, yes,
please?
yes. It is a blood patch. Contraindications for blood patch.
Yeah. Contraindications for blood patch. Okay, ma'am. Can you take that question, ma'am?
I don't think there are any contraindications per se, except that if you have a systemic infection or a local infection or any sepsis or bleeding disorder, or use the start of blood thinners have taken place, or if the patient refuses the procedure.
Yeah, almost all the contraindications you've highlighted. Dr. Reddy, can you have more answers to it? Any contraindications which you have encountered while trying to attempt for epidural blood patch?
Known case of HPSAG positive, known case
Okay.
of HIV, we are directly instilling into the central nervous system.
So that
One
should
of
always be
the top.
avoided.
Okay, that's why.
Yeah.
Okay.
Thank you so much, sir. Thank you so
Thank you,
much.
sir.
We still have 2 to 3 minutes. We would be happy to take more queries.
Or we can have the audience telling us about their experiences, if they experienced any rare complication or something.
Yeah. So recently, my experience that I was attempting an epidural blockade in a patient for pain management, and I had given around 15 ml of uh, 0.25% bupivacaine, and immediately after the epidural, there was intractable coughing for almost say it was around 4 to 5 minutes, and it was very severe coughing. And but patient was conscious oriented, the vitals were stable. Almost after 5 minutes, the patient stopped coughing, and we went through the literature, and predominant mechanism involves the sudden stimulation of the vagal nerve, because either the some of the drug might have entered the subdural space, or probably that epidural space might have been constricted and could have been high epidural, and the predominant mechanism uh, was involvement of the vagus nerve. And then we published it in Journal of Pain and Palliative Pharmacotherapy as a case report. But that was interesting. Uh,
I think we can have Sir giving us some inputs.
yeah.
Naveen sir and Rajiv sir.
Rajiv sir, Naveen sir, years of experience, stalwarts. Can we have your opinion, sir? So I think we are on time. That is the most beautiful part. We still have delegates uh, logged in. That is again very enthusiastic on their part. Thank you so much, Professor Parul, for such a wonderful presentation and highlighting important points. Thank you to all the delegates uh, for attending the lecture so attentively and participating in the questions put forth by Dr. Parul. The final words from Dr. Rajiv sir and Dr. Naveen, if any.
Thank you, Dr. Parul, for sharing your time, experience, and knowledge with the delegates. And I hope the delegates would have enjoyed that conversations and the discussions. And those who have missed it, the recording is definitely available. And God bless you all. Thank you, Dr. Ankur and Dr.
Thank you,
Parul.
sir.
Keep on doing good work and keep on spreading the knowledge far and wide. This is
Yes.
just the beginning. And Ankur, you
Thank
have
you,
been
sir.
moderating for a long time. Next,
Yes, sir.
be ready to deliver a class. Now,
Sure.
you youngsters have to come forward and become masters.
Thank you
So,
so much, sir. It would be my pleasure.
thank you very much. Over to you, Dr. Rajiv.
It was a very good session, Dr. Parul. You did proper justice to the complications of regional anesthesia. Though it looks very simple, regional anesthesia ठीक है, स्पाइनल लगाना है, एपिड्यूरल लगाना है, ब्लॉक लगाना है, अल्ट्रासाउंड है, सब कुछ है. But we should know what are the complications, and we should always keep in mind about the patient. See, you are You may be learning, you may be asking your PG to get it done, but you have to be at the head end. You have to see that how they are doing. So what is the actual procedure and what they are doing, it should be properly observed and they should be guided properly. So normally, complications are not there. So we are a bit reluctant about so many things. But no, in anesthesia, observation is very, very much required, and it is the first and foremost quality of an anesthesiologist. So I think Dr. Parol has very nicely elaborated each and everything, and all the PGs must have been benefited by her talk. So thank you very much, Dr. Parol, Dr. Ankur.
Thank you so much, sir.
Thank you so much, sir.
Thank you. Long live ISA.
Long live ISA. Jai Hind.
And
Jai Hind.
we will not, thank you very much, and we will not stop it, because the same link will be used for inauguration of ISA Caracal City branch in the state of Puducherry. It's a hybrid inauguration. So I think 8:30 is the time. So we are well in time. So those
Good
who
evening,
want to,
sir. Good evening, everybody.
those who
I'm
want
Dr.
to,
Dr.
Nagalakshmi.
Nagalakshmi.
Hello, sir.
Good evening,
Hi,
ma'am.
ma'am. Hi, ma'am. Hi, sir. Hi. Hi, everybody.
Nice to see you, ma'am, after a long
Yeah.
time.
Yes, Ankur. Pleasure is mine.
Yeah.
So we have our ISA Karaikal City branch people. They are joining us from their place. They have all assembled together in the place. So they will coordinate. Dr. Jaya will be, who is the member secretary from ISA Karaikal City branch, will coordinate this, sir. She will
so
be
I think well begun is half done. So if everything is fine, we can begin.
Dr. Jaya, can you unmute yourself?
Hello.
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 Hi, sir. Hi, sir. Our state branch president, Dr. Sunit sir, is also there. So,
Hello. Good evening. Good evening, everybody.
Good evening. So over to you, Dr. Nagalakshmi, to carry on the proceedings.
yes, sir.
And I am thankful to to Caracal branch to understand that the class time is now 8:30, 7 to 8:30 p.m. So that's why this inauguration has been rescheduled to 8:30. Over to you, Dr. Nagalakshmi.
Thank you, sir. So, from the city branch of Karaikal, Dr. Abhinaya, who is the assistant professor in JIPMA, she will be coordinating and hosting the ceremony. Over to you, Dr. Abhinaya.
Thank you, ma'am. Good evening, everyone. It gives me immense pleasure and great sense of pride to welcome you all for the special occasion, the inauguration of Indian Society of Anesthesiologists, Karaikal City Branch. On behalf of ISA Puducherry, I extend my warmest welcome to all distinguished dignitaries, senior colleagues, members of ISA, and friends who have joined here in person and virtually. To set our proceedings in motion, I invite Dr. Suneet P. Lazarus, ISA Puducherry State President, to deliver the welcome address. Over to you, sir.
Good evening, one and all. Respected ISA National President, Professor Naveen Malhotra, sir. Honorable National Secretary, Dr. Rajiv Gupta, sir. Esteemed patrons, distinguished dignitaries, senior members, and respected colleagues. A very good evening to one and all. It is my great privilege and honor as the President of ISA Puducherry branch to extend a very warm and cordial welcome to all of you on this memorable occasion. Today marks a significant milestone in the history of ISA Puducherry as we come together to formally celebrate and embark upon a new chapter of academic excellence, professional collaboration, and service by the establishment of a new Karaikal City branch. At the outset, I would like to express my deepest gratitude to our respected National President, Professor Naveen Malhotra, and Honorable National Secretary, Dr. Rajiv Gupta, for their gracious presence, encouragement, and continued guidance. Your leadership and support have been instrumental in bringing this Karaikal City branch into existence, and we are truly honored to have you with us today. I also extend my sincere and heartfelt welcome to our esteemed patrons, whose wisdom, experience, and constant encouragement will serve as a strong foundation for the growth and the development of this new city branch. My warm welcome to all the distinguished office bearers, senior members, colleagues, and faculty members who have joined us today. Your presence makes this occasion all the more special and meaningful. The establishment of Karaikal City Branch is not merely the beginning of another organizational unit. It represents the beginning of a shared vision, a collective responsibility, and a commitment to advancing our profession through knowledge, education, research, innovation, and service. As we begin this new journey, I am confident that with the guidance of our national leadership, the support of our patron, and the active participation of every member of new branch will grow into a vibrant and academically enriching platform. I would also like to place on record my sincere appreciation to everyone who worked tirelessly towards the formation and the successful establishment of the new branch. This achievement is truly the result of collective effort, dedication, and teamwork. Let us look forward to building a branch that stands for excellence, integrity, inclusiveness, collaboration, and continuous learning. Once again, on behalf of the entire ISA Puducherry, I extend my heartfelt gratitude and very warm welcome to our National President, National Secretary, patrons, distinguished guests, and all our members. May this new city branch, Karaikal, mark the beginning of a successful, purposeful, and inspiring journey. Thank you all for being a part of this historic occasion. I wish the newly established Karaikal City branch every success and a very bright future. Thank you and a very warm welcome to you all. Long live ISA.
Thank you, sir, for setting such a warm and inspiring tone for the event. So it is now our distinct honor to hear from our ISA National President, Dr. Naveen Malhotra, sir, to address the gathering. Over to you, sir.
Thank you very much. Dr. Rajiv, can you make me co-host? See, whenever we bring any new thing and inaugurate a particular branch, we should always salute our ISA flag. So it's my honor to do the digital flag hosting of ISA flag before I speak my few words from my heart. Long live ISA, long live ISC. Respected and dear ISCians, it's really a historic occasion because we are doing today a hybrid inauguration of ISA Karaikal City branch today on 17th August 2026. This is the second branch in the history, or I will say third branch. First branch was Noida Gautam Budh Nagar, which was inaugurated in hybrid manner. Second was Agroha in Haryana, and this is the ISA Karaikal City branch, which is being inaugurated in hybrid manner. Rest two were in during COVID times, but I'm very happy that Dr. Nagalakshmi could do that because this branch was approved by ISA Governing Council in January 2026. And was allotted an ISA sponsored CME also, wherein when I discussed with Dr. Nagalakshmi that we will do inauguration as well as the scientific program. I understand that the Puducherry State Branch has a conference next week, so logistically it will be difficult to do a CME. That and don't get disheartened, Karaikal City Branch people, our friends there. You can do that ISA sponsored CME till March 2027. And best wishes for your state branch conference, which is on the third weekend of September.
Thank you.
Dr. Suneet P. Lazarus, the president of ISA Puducherry branch, Dr. Nagalakshmi, the secretary, the chief patron, Dr. K. Charan, and patron, Dr. Prasanna Vadanan. And heartiest congratulations to the founder president of Karaikal City branch, Dr. K. Suresh, founder secretary, Dr. Jaya V, founder treasurer, Dr. Balachandar S, and all the executive members, Dr. Om Prakash, Dr. S. Arun Kumar, Dr. A. Alexa, Dr. Abhinay R, Dr. Kamaladeen, Dr. S. Sundar Pandian. I am very, very sure that it will be a very vibrant branch of ISA. When you are ably guided by the leadership of ISA Puducherry, and I can tell you, when I was secretary, I had a close interaction with Puducherry leadership. Puducherry branch is very, very meticulous, and they follow the three mantras which I follow in my life: honesty, sincerity, and hard work.
Yes, sir. Thank you.
They are simply the best. So I'll give you some agenda. First and foremost is that you have to conduct ISA Panch Rakshak program in the all the activities which you do, whether it is a city branch activity or state branch activity. And as you all understand that Panch Rakshak program of ISA National is teaching layperson 5 life-saving skills. Each one of us should teach at least 5 laypersons, the drivers, the chowkidar, the domestic help, 5 life-saving skills in the form of compression-only life support, leg raise in case of syncopal attack, unconscious patient recovery position, choking, abdominal thirst, and presence of emergency medicine kit in each home, including 4 tablets of 75 milligram aspirin, 4 tablets of 75 milligrams clopidogrel, 4 tablets of atorvastatin, and 4 tablets of sorbitrate. And dear ICNs, this emergency kit should be there in your home also. So that is one. And do report. There is a Google form which Dr. Nagalakshmi will share with you so that it is recorded in the national database how many people we have trained in a calendar year. Secondly, under the banner of College of Indian Society of Anesthesiologists, centers of excellence are being established across the country. And I give this responsibility to Puducherry and Karaikal to have an individual center of excellence, wherein you teach and train people in the nearby states in whichever field you think you are best. If you think you are best in airway, you can start a fellowship in airway. If you feel that you're good in USG, you can start a fellowship in that. Thoracic, cardiac, neuro, pediatric, pain, critical care, whichever field you think that you are good, you can start as long as 1 year fellowship course, a 6-month certificate course, or a shorter refresher course or orientation course. It depends upon you. It can be over the weekend or it can be for 1 year. But I wish that before we meet in Trivandrum, Dr. Nagalakshmi and Dr. Sunit will ensure that there is a proposal from from Puducherry as well as Karaikal. I can tell you with full confidence Uh, Dr. Rajiv Gupta and the National Secretariat is working overtime. And I hope Puducherry would have received its grant in aid by now.
Yes, sir.
And
We have
yes,
received it,
okay,
sir.
fine.
Thank you so much, sir.
No,
Thank
no,
you.
see, it is your money.
Yeah.
It is the money of the state and the members. It has to be used for that purposes only. The
Yes,
only
sir.
thing is the CA says there should be a bank account in which we can transfer the money.
Yes, sir.
Otherwise, we cannot send the money like this.
Yeah.
Okay, so thank you, Dr. Nagalakshmi, for sending all the reports. And I am very sure that this grant in money aid will be utilized for member welfare activities in the coming months and years. And best wishes for your conference. ISA National is just one phone call away, one email away. Any of you who want to participate in ISA National academic programs, maybe in the national conference, workshop, CME, or national classes, please send your interest along with your CV to isafacultypool@gmail.com. I repeat, isafacultypool@gmail.com, and it will be given importance at one or the other platform. Our personal emails, president isaNHQ@gmail.com and secretary isaNHQ@gmail.com is always there for you. And if there is anything which you want to convey to us, you are most welcome. And we are all ears to some harsh comments also, to some constructive inputs also, including constructive criticism. Finally, there are so many programs being done by ISA. Do take care of yourself also. As a form of the ISA Fit Anesthesiologist campaign, Project Vocesthesia, right? Aesthesia means senses, anesthesia means loss of senses. So we have this Project Vocesthesia in which we walk through the senses and keep ourselves fit. We have got ISA Lifestyle Car, where the four wheels should be balanced, whether it is sleep, whether it is nutrition, whether it is spiritual health, and whether it is physical activities. Same way, do contribute to the environment. Breathe Green is another project of ISA in which we are giving oxygen to the environment. We all understand that oxygen is very important for patients. We check the cylinder, we check the pipeline, but we have to give oxygen to our Mother Earth also. So ensure that you all plant at least one tree in a year. On your birthday, on your son's birthday, on your parents' birthday, on your marriage anniversary, and take care of that. We are soon going to form special interest groups under College of ISA, wherein all the specialties of anesthesia, sub or super, there will be special interest group. If you are interested to join such a group, if you're interested to lead such a group, please write to isafacultypool@gmail.com. And this year at the national conference, we're going to have a ISA Medical Education Summit. It's a new program, and also a simulation contest where top 10 teams will be contesting on Thursday, the 25th of November, and the winner will go to the international event at Malaysia next year. We are liaising with both national and international societies and our sister specialties in India. We have got MOU with all the sister specialties in India. ISA is active in SARC Association of Anesthesiologists, Asian Australasian Regional Section of WSA, and the WSA Council and Board. And as you are all aware, that World Congress of Anesthesia 2030 will be in India. So the future is bright for all of us. But I always say, think global, act local. Act local. So strengthen the periphery. Every last anesthesiologist in the remotest of district should be fully trained, fully qualified, and fully protected. This is the responsibility of ISA National along with state and city branch. And every last patient in the last district of the country should receive safe anesthesia from a qualified anesthesiologist. With this, I congratulate all the office bearers, members of Karaikal as well as Puducherry, and wish them good luck and feel proud of yourself and make us also proud. Long live ISA, long live ISCN, Jai Hind. Thank you.
Long live ISA, sir.
Long live ISA.
Thank you, sir, for your visionary message on leadership. Next, I invite our National Honorary Secretary, Dr. Rajiv Gupta, to share his remarks with us.
Respected President, ISA National, Dr. Naveen Malhotra, President Puducherry, Dr. Sumit, Dr. Nagalakshmi, Secretary Puducherry, patrons, Dr. Sharon, Dr. Prasanna, and newly formed President Dr. K. Suresh, Secretary Dr. Jaya, and Treasurer Dr. Valachandran, and all other executive members and leaders of Karaikal and Puducherry. Inauguration of ISA Karaikal City Branch. What a pleasure and pride to be here at this historic moment. On behalf of ISA National, I extend my heartiest congratulations to all the members of Karaikal and to everyone whose vision, commitment, and hard work have made the formation of this branch possible. It is the beginning of new academic and professional journey and the addition of other strong links to the ever-growing ISA family. Karaikal, as we know, is a unique heritage among the strong healthcare community with so many medical colleges and great organizations. A platform where we can learn together, grow together, and serve together. The real strength of Indian Society for Astrology lies in its members and its city branches. But it is city branches that takes the vision to the grassroots through CMEs, workshops, skill development programs, public awareness activities, member welfare, and community service. As Dr. Naveen has already described all the national programs, what we are doing and what we are looking at, its members, its city branches and state branches. Under this newly formed branch, I think academics and training, they are one of the strongest pillars. So we hope that you will organize regular clinical meetings, case discussions, workshops, simulation-based programs, and most importantly, involve your young anesthesiologists and postgraduates. Because they are the future of ISA, they are the future anesthesiologists and the future leaders. So they need to be sensitized regarding education, activities, about the environment, about their health, about their nutrition, everything. So they should not feel like burnout. We need to support them in all their endeavors. ISA is a professional family. We should together celebrate all our achievements. We should stand firmly with all our colleagues in all the thicks and thins. We should organize welfare programs, personal and professional dignity with professional dignity, and we should support them all in all round their activities. Along with academics, we should ask them to take part in extracurricular activities and their hobbies. Like in national programs, we are doing cultural programs, sports activities. Then some people, they are good at writing, some are good at photography. So try to hold various programs where they can showcase Other than academic activities, they can showcase their hobbies also. And, and we need to, incentivize them, give them prize, who are doing good, who are doing best, ask them to participate in all the ISA national activities. So this is very important for all the city branches. Now we are heading towards World Anesthesia Day also. So in that, as Dr. Naveen said, we need to perform this Pancharakshak program, CPR trainings, and we should celebrate this World Anesthesia Day in a way that is memorable to each one of us. So once again, I would like to thank the founding president, secretary, and executive committee of this new curricle branch so that they can work together, they can work hard to achieve more and more. Thank you. Long live ISA. Jai Hind.
Thank you very much, sir, for those insightful words. Now, to formally introduce the leaders who will guide this new branch, we welcome Dr. Nagalakshmi ma'am, ISA Puducherry State Branch Secretary, to introduce the city branch office bearers. Over to you, ma'am.
Thank you, Dr. Abhinaya. I would like to tell you a little story about the formation of ISA Karaikal branch. We Puducherry, we are unique because we are an union territory, which is a congregation of 4 cities. Karaikal, which is enclaved by Tamil Nadu, Mahe, Yanam, in 4 different places. The administrative place is Puducherry, but Karaikal is enclaved by Tamil Nadu. So there are geographical limitations in traveling, in accommodating the city branch members, but still we have quite a few number of anesthesiologists in Karaikal branch also, and we thought of creating a city branch. It has been long in the pipeline, and under the guidance of our Honorable National President, Dr. Naveen Malhotra, and Dr. Rajiv Gupta, Honorary Secretary, we would like to formally inaugurate and introduce the city branch members, founder members. The patrons are Dr. Cheran sir, who's a dean in Vinaya Missions Karaikal, and Dr. Prasnavadhanan sir, who's a HOD Department of Anesthesiology from Vinaya Missions Karaikal. And the president is Dr. Suresh, who is the HOD Department of Anesthesiology, Government General Hospital Karaikal. And secretary is Dr. V. Jaya, who's the associate professor in JIPMA Karaikal. And treasurer will be Dr. Balachanda, who's an associate professor in JIPMA Karaikal. And all other executive members are Dr. Om Prakash, Dr. Abhinaya, Dr. Kamaluddin, Dr. Mannar Mannan, and Dr. Alexa and Sundar Pandian. Thank you all. And I wish all the best to all the city branch members, founder members, and this marks a remarkable journey in the academic achievements and further events. Thank you. And I would also take this as an opportunity to invite you all for the upcoming state conference, 17th annual state conference of Puducherry, which is conducted in Puducherry on September 19th and 20th. Thank you.
Thank you, ma'am. We'll now hear from the guiding pillars of the newly formed local branch. First, I'd like to invite our city branch chief patron, Dr. Cheran sir, Dean, Vinayaka Missions Medical College.
Very good evening to all. Actually, today I had a treatment for last city, so I can't speak much. Especially Naveen Malhotra sir, especially Rajiv sir, my dear friend Dr. Suresh, Jaya madam, and all others. All the best. Hope we'll do the better. Thank you.
Thank you, sir. Now I request our city branch patron, Dr. Prasnavadhanan sir, HOD, Vinayaka Missions Medical College, to share his words of wisdom with us. Over to you, sir.
A very good evening to everybody. So we've been in Karaikal for quite a long time. Myself, Dr. Charan sir, and Dr. Suresh sir was a senior most qualified anesthesiologist in Karaikal. And when we came here, it was just a couple of hospitals and a few qualified anesthetists who are managing all the cases. Now, when we see the development, we have so many qualified anesthesiologists, so many hospitals, and so many complicated surgeries are going on. And our Vinayaka Mission Medical College, under the leadership of our dynamic dean, we've been doing a lot of academic activities, and we've been training several generations of postgraduate students in safe and quality anesthesia. Now, I want to congratulate the team from JIPMER, Dr. Jaya, Dr. Om Prakash, Dr. Balachandran, of course, Dr. Alexa, who were playing a very important role, and they had this dream of starting our own city branch for quite some time. And I'm very happy to see it has been brought into action now. As patrons, we will definitely guide you, and whatever help you need regarding the organization of academic events or providing or encouraging our postgraduates to take active part in the organizational events, will be always there to help you. A sincere thanks to ISA National President, ISA Honorary Secretary, ISA President Puducherry, and the Secretary for their support. And I hope ISA Karaikal will definitely occupy a distinct place in the map of ISA. Jai Hind, long live ISA. Thank you.
Thank you, sir. I now have the pleasure of inviting the newly inducted City Branch President, Professor Dr. Suresh, to deliver his address. Please.
Good evening, respected ISA National President Dr. Naveen Malhotra, National Honorary Secretary Dr. Rajiv Gupta, ISA Puducherry State President Dr. Suneet P. Lazarus, State Secretary Dr. Nagalakshmi, Chief Patron Dr. Charan, Dean, Vinayaka Mission Medical College Hospital, Karaikal, Patron Dr. Prasanna Vadanan, HOD, Department of Anesthesiology, Vinayaka Mission Medical College, Karaikal, senior colleagues, office bearers of ISA, distinguished members, dear ISANs, ladies and gentlemen. It gives me immense pleasure and great sense of pride to be with you all on this special occasion, the online inauguration of Karaikal City Branch of Puducherry State. At the outset, I extend my warmest greetings and congratulations to Dr. Nagalakshmi, Puducherry State Secretary, and Dr. V. Jaya, Associate Professor, JIPMER Karaikal, and other office bearers who have worked relentlessly to establish this new branch. I extend my heartfelt thanks to the National President and Honorary Secretary for supporting us to establish this Karaikal City branch. The formation of a new ISA branch is not merely an administrative milestone. It represents the beginning of a new platform for professional fellowship, academic growth, mutual respect, and better patient care. Today marks a new beginning. Every branch starts with a vision. That vision becomes meaningful when it is transformed into action through the dedication of its members. I am confident that this new branch will become a vibrant center for academic activities, continuing medical education, workshops, scientific discussions, and professional development. More importantly, I hope it will create a strong sense of fraternity among anesthesiologists in this region. As we move forward, let this branch become an advocate for safe, evidence-based, and ethical anesthetic practice. Once again, I congratulate the founding members, office bearers, and organizing team for this important achievement. I also acknowledge the support and guidance provided by the Puducherry State leadership and ISA national dignitaries. I encourage all members to actively participate in the activities of the branch and make it a center of knowledge, friendship, professional excellence, and service. My heartfelt congratulations and best wishes to all of you. Long live Indian Society of Anesthesiologists. Jai Hind. Thank you.
Thank you, sir. We look forward to dynamic leadership and progress under your tenure. Now, to conclude this historic ceremony, we invite Dr. Jaya, Dr. Jaya, Associate Professor, JIPMER, and Member Secretary to propose the vote of thanks.
Good evening, everyone. Before starting my vote of thanks, I invite everybody for the upcoming ISA Puducherry State Conference. We'll see a video for that. Video. Ma'am, we are not able to share.
Dr. Rajiv, you have to make them co-host. Who has to make co-host?
The ISA Karakal.
ISA conference.
ISA Karakal. Dr. Rajiv, make them co-host, please. Yeah, please go ahead.
Video. Share. India is praying for.
Jay, is it playing?
Yeah. I hope everybody will meet in the ISA Puducherry conference. And at the last time, respected Dr. Naveen Malhotra, President ISA National, Dr. Rajiv Gupta, Honorary Secretary ISA National, Dr. Sunit P. Lazarus, President ISA Puducherry State Branch, Dr. Nagalakshmi P. Secretary ISA Puducherry State Branch, and Dr. Cheran, our Chief Patron, and Dr. Prasanna Vedan, our Patron, and Dr. K. Suresh, President ISA Karakal City Branch, and my fellow office bearers, executive committee members, and dear colleagues, and ISA Puducherry members who are joined in online. Good evening to everyone joining us on both in person and online. It is my privilege to propose the vote of thanks on this truly memorable occasion, the inauguration of the ISA Karakal City Branch, a long-run dream of me, the first city branch under ISA Puducherry State. I would like to begin by expressing my heartfelt gratitude to our ISA National President and ISA National Honorary Secretary for gracing this event with their presence online and for their inspiring words which have set the tone for the journey ahead of us. My sincere thanks to Dr. Sunit P. Lazarus, President ISA Puducherry, for his constant guidance and support in helping us to reach this milestone, and especially to Dr. Nagalakshmi, who helped me in every step in formatting and organizing this city branch, and help us and expect to help in the upcoming time also. I'm deeply grateful to Dr. Cheran, Dean, VMC Karakal, and Dr. Prasannan Vadanan, HOD VMC Karakal, who are accepting to be our chief patron and patron respectively, and for their unwavering encouragement in establishing this branch. Their mentorship gives us the confidence to take this forward. I thank Dr. Suresh sir, our president, for his vision and leadership in bringing together anesthesiologists from JIPMER, VMMC, and GGH Karakal under one banner and for steering us to this day. My thanks also go to the Dr. Balachandaras, our OAC treasurer, and to all our executive committee members for their tireless efforts behind the scenes in planning this event. I would especially thank to the Dean, JIPMER Karakal, and their administrative for kindly granting us this venue and for their institution's generous support for hosting this inaugural function. I have a sincere thanks to OACs of housekeeping, security personnel, and IT wing of JIPMEC Oracle, whose quiet and dedicated effort behind the scenes, from setting up this call to ensuring smooth hybrid connectivity for our online participants, made this evening possible. I deeply appreciate their support. I also extend my warm thanks to all our ISA Puducherry members who joined us online this evening. In spite of short notice, your presence, despite not being with us in person, reflects the spirit of unity that binds our state branch together, and we are grateful for your time and support. Finally, my heartfelt thanks to all our founding members and every one of you who took the time to be here today in person and online to witness and support this important meeting. Your presence truly makes this occasional meaningful as we take our first steps as the first ISA Coracle City branch. I look forward to your continued support, participation, and commemorate in the years to come. Long live ISA. Thank you.
Thank you all.
Rajiv sir.
With
Sir.
this, we close this inaugural ceremony with heartiest congratulations to all. Namaskar.
Thank you. Thank you.
Thank you, sir.
Thank you so much.
Thank you.